Good morning, Lila. Thank you so much. And hello, everybody. It's my pleasure to talk about measurement-based care. I've been talking about it for quite some time now as this initiative has been taking fold in our field. So I'll go ahead and get started on our wonderful presentation today and talking about measurement-based care. It's interesting because the title that I'm using and I've been using for the last few years has been the what, the how, and the why bother. And I always giggle when I think about this because it always reminds me of the spaghetti western with Clint Eastwood, the good, bad, and the ugly. And and I would imagine that any good clinician who hated statistics and hated research methods would in fact really think that measurement-based care is a lot of good, bad, and mostly ugly. But the truth is, there's not a lot of bad with regard to measurement-based care. In fact, there's no bad at all about it, and that's what I'm going to talk about today. However, the how piece of it, with regard to methods and psychometrics, knowing your psychometrics and operationalization, I would imagine would be that that ugly that a lot of people might think about when it comes to implementing measurement-based care into your practice. So what I thought today is this is a nourishment seminar. And when I talk about measurement-based care and all of the aspects of what it is, how do you do it, and why should you even bother doing it, this could be at least an hour and a half presentation to up to 4 to 6 hours for a day seminar. But this is a nourishment webinar. I'm thinking, how can this be a nourishment topic, right? And then I thought about it, you know what, with regard to the how, it can be a nourishment. And this is how measurement-based care can nourish. Not only can we look at it in terms of how it might nourish your clients, which I'll talk about, but how it can also nourish your practice and your programming. And at the end of the day, my friends, how can measurement-based care actually nourish you? So that's the focus I want to take. And we're not going to talk about any of the ugly, but we're going to get into the goodness of measurement-based care. So basically, what is it then? The standard definition to date is that measurement-based care defined is the systematic administration of symptom rating scales, psychometrically sound symptom rating scales, to drive your clinical decision-making and help you plan your treatment and then gauge treatment progress at the level of the individual patient. An individual patient, I think, is the critical piece here because measurement-based care is not outcomes per se as much as it is a clinical tool to help you with the work that you do. So what does that look like? So let's just put it into some images because I'm very visual when I learn. And so what does measurement care actually look like if we were to put it into a visual? So let's take time, right? And your patient comes to you prior to working with you. And during the intake process, you may ask them to complete a few symptom scales. Now, this actually takes a lot of thought to do correctly. I often tell my clients, you need to dig down deep and understand what your value system is, what your expertise is, what's the mission and vision statement of your practice. And that's how you're going to gauge what kind of psychometric scales to choose to give to your patients, right? At Sierra Tucson, we do a comprehensive profile that we give to each one of our patients. We have 4 distinct programs. We have addictive co-occurring, we have mood, we have trauma recovery, and a chronic pain recovery program. If I were to give each individual patient a unique set of scales based on the program they're entering, it would be an astronomically huge endeavor that could never be conducted. So what we've decided to do is do a comprehensive assessment for every single patient. And the reality is comorbidity is a real thing in our field. So we want to touch on all of those things in regard to mental health quality of life. So we measure for depression, we measure for anxiety, we measure for PTSD, and we use the ACE as well. We measure for quality of life functioning, we measure for coping and stress, we have a few measures there, and then substance use. So our patients complete something of this nature, and your patients would probably complete something that you would identify would speak to your practice. And then we have the clinical interview, the first interview. Now, measurement-based care is not designed to supplant the goodness of your work. It is there as a tool to augment what you do. So you continue doing you in the clinical interview and how you do your intake. But the idea here is to use the data from those measures to help support and maybe open up some questioning that you might not have thought to do or the patient didn't even think to bring up. It's that kind of nuanced additional method that allows you to really make a more thorough, thoughtful, unique targeted treatment plan. From there, during the progress of your psychotherapy with the patient, measurement-based care is for you to repeat the evaluation based on how you design when you want to have it done. Is it weekly? Is it after every session? Is it bi-weekly? Is it monthly? It really is designed by you, how it works for your practice. At Sierra Tucson, we get people for 30 days on average. And so what we like to do is do one-time mid-treatment evaluation. So that's how we have defined when to do our progress monitoring. And it's here that you can review the data, the progress with your patients during a regular therapeutic encounter. So it's an additive measure that you bring into it. And you can identify if the patient is on target, right? Are they meeting the treatment goals? Are they actually doing better? This is a cause for celebration and reflection. It's very therapeutic. And one of the most important features is, are your patients not progressing as planned? And that's very critical to measurement-based care. And this is one of the reasons why JCAHO has been pushing that all facilities that under their accreditation use measurement-based care. Because if we do find some treatment failure, or even if patients are not making any progress whatsoever, inertia, it allows us to go back into the treatment plan to make adjustments. Because the idea here with measurement-based care is that you are supporting the treatment process for your patient. We want to make sure at every point in time that we're doing the right course of treatment for the individual. So the essence of measurement-based care then is to use those sound scales as tools clinically, okay, not in terms of research, but use them clinically to understand your patients better, to assist in the treatment decision-making process, to monitor treatment progress, and which means to prevent treatment failure if you can, and also to measure treatment success. And this is one of the reasons why both JCAHO and CARF are asking and requiring their accreditees to use it. JCAHO made some changes to their outcome measures standard back in 2018. CARF has been doing this for a little longer, since 1998, to implement some form of measurement-based care in your practice. So let's talk about the why then, before we get to the how. And so the why of measurement-based care is actually a very rich body of research. There's been a lot of excellent studies that have come out in the last 20 years, some actually randomized control trials, believe it or not. Well, not so much randomized, but using psychotherapy programs to assess those who are receiving measurement-based care or progress monitoring and those who are not. So some really good studies that have been done through the years. Scott Miller is one, Michael Lambert is another, if you're interested in reading in the field. And so the why bother is one of my favorite things to talk about. And I'm really hoping at the end of today's session that you'll walk away understanding that, oh, this is a really good thing and I really should be doing it. So if I've convinced you at the end of 25 minutes, then I've done my job today. So why bother doing it? So what are some of the benefits for your patients or your clients? Is the first one is insight. When we talk about insight, when an individual comes to you with a suffering issue or symptoms, oftentimes they have an idea or they think they know what's going on with them. And so they will present to you their story. When they complete a questionnaire, oftentimes the data from that information will give them further insight to what's happening to them. Oh, this is depression. This is what I'm feeling. Or, oh my goodness, this is your social anxiety. I wasn't sure what that is. And so it really helps to deepen the insight the patient understands about themselves. The other one, of course, is our favorite, is therapeutic alliance, right? And so therapeutic alliance is critical to successful psychotherapy. We all know it to be true. Back in the day, we used to call these the unspecified measures or the unspecific variables in research, right? They were the nuisance variables. But the reality is that therapeutic alliance is critical to successful psychotherapy. And so what we are finding, and John Fortney talks about this in his Tipping Point article, Scott Miller also speaks about it as well, is when a patient is experiencing you talking about their issues and then talking about how they responded to a variety of measures, they really get the sense that you're caring at a deeper level. So they see you as taking their treatment seriously, and it really adds to the trust and the connection that they feel toward you with regard to that relationship building. Hope is a really important factor. And what we're finding here is when patients are observing their progress data, 1 to 2 points at minimum change can make a huge difference for an individual. And one of the things that Jon found in his study for the treatment outcomes package is this really seemed to appeal to the depressed patients. When they were able to see 1 or 2 points of change, some got to see 5 and 10 points of change, but it was enough for them to say, oh my gosh, this is working, I am making progress. They may not know it, clinically from their own perspective, from their subjective perspective, but there's something magical about seeing change in a data record that really seems to solidify for patients. Now, this leads us into treatment compliance, and right, if the patient is seeing that there's something good about the program that they're doing, there's hope that they're actually making progress, chances are they're going to stick with it. And treatment compliance is a big issue in our field. And what we're finding is that measurement-based care might be part of the solution to that issue. Lastly is clinical satisfaction or patient satisfaction. Again, a number of studies have shown, and the early research with Scott Miller's group looking at the ORS and the SRS, is that patients who are experiencing review of their data as part of their psychotherapy process to be really trusting in the process and really feeling good about their psychotherapist. And so they really felt a lot of satisfaction in the treatment that they were receiving. So these are a couple of positive points that measurement-based care can do for your patients. But they're not the only part of the issue here. It's you, the providers. So how can measurement-based care nourish you? What can it do for you? Understanding and tailored treatment planning, right? So not only does the patient gain insight when they look at their initial measures, but it allows you, the clinician, maybe a few extra kernels of information that you may have not asked about, your patient may not have brought up, right? And so it really deepens your clinical conceptualization process. This in turn allows you to develop and focus on a targeted therapy more specific to your patient. Therapeutic alliance, my friends, goes both ways. What can I say? It's not just how your patient feels towards you and how they connect with you, but it's also the non-specifics that you feel in regard to your patient, because relationships take two people and we are in a people business. So when we use measurement-based care in a clinical sense and the patient feels closer to you and trusting you more, it allows you that same sort of bonding with them. Reducing treatment failure is probably the most important feature of measurement-based care. I touched on it earlier. What we want to be able to do here is be able to capture patients before treatment fails. So what we're finding, and a lot of researchers are looking at this, especially Michael Lambert in his work at Utah, and he actually wrote a book, so I have a reference for you there, is how do you prevent treatment failure? Well, one of them is to use measurement-based care. And if you do your systematic monitoring, you're going to be able to capture nuances of non-progression or inertia before treatment is failing your patient. It is a critical piece, and I can't express that more and encourage you to consider it, because treatment failure can look like an AMA. It could look like no change at all. It could look like disengagement. And so when we're using monitoring scales, we can actually catch it. So it's really critical to the work that we do. Job satisfaction. All right. So we are in the people business, right? And we have high levels of caregiver burnout. And this is a really critical feature, I think. So not only does your patient get the report card that they're doing well with regard to how you graph their outcomes, their data, but it's really a report card for you too. And in our field, while we are dealing with a lot of suffering and a lot of sorrow that comes to us, to actually see our patients progressing can really lend itself well to how we feel about our jobs and being satisfied by that. So let's talk about the how of measurement-based care. So how really can it nourish you? So what I've done is I'm taking the what is it and the why bother with it and sort of integrating on how it can nourish you. So let's go back to our time diagram that I used earlier. So your patient is completing their assessments, and we have the clinical interview where you're talking about the data in addition to doing your own intake process. And during that process is added insight for you and your patient, understanding, especially for understanding how the patient is responding to questions, maybe digging a little deeper and why they answered a particular question a certain way. It allows for stronger alliance on both accounts, and then communication. It's an enhancement to communication, because one of the critical features for our patients is the desire to be heard, right? So they see you as a therapist who's listening to them, taking good notes, thinking about their issue, but you're also paying attention to how they're reporting on a questionnaire, which allows for further communication. We get the tailored treatment plan, the personalized care. That's the big sexy word in our community now. I used to call it patient-centered medicine, but now we're looking at personalized psychiatry, but really allowing for more of a personalized treatment plan. So it's not the cookie cutter approach to treatment. So the patient feels special and you feel good that you're doing the right thing. Repeat testing during treatment. Here we have an opportunity to monitor how well they're doing. We're going to prevent treatment failure if we can, and also the opportunity to celebrate treatment success. So putting it all together, this is how it can really nourish you and your patient. So what I wanted to share with you here briefly is actually some feedback I got from one of our primary therapists. Back in 2019, we had done a pilot, and it was a very special way of doing measurement-based care. During the mid-treatment evaluation, the patient would complete the data, and both the provider and the primary therapist would meet with the patient. We really wanted to try this sort of interactive opportunity to discuss the data together, see how well they were doing in treatment, what could they do to make the treatment better, more specific, and what about continuing care. So it was a really nice integrated meeting. And so this primary therapist wrote to me, she said, the collaboration of the team is one of my favorite parts of measurement-based care. Patients feel like they're getting great care because it's very clear that the treatment team was communicating and invested in them. They really appreciated seeing the data progress as well as about hearing their progress. The mid-treatment evaluation allowed us, the treatment team, to collaborate on reiterating the importance of continuing care, and 2 of my patients changed their mind and agreed to sober living based on that meeting. So what had happened is she was referring to 2 addictions patients who were like, once I'm done with this place, I'm going to go off back to my life. And so when they had their mid-treatment evaluation meeting, they saw the progress, they saw some issues that were not improving, and they realized that the treatment was supporting them and they still had work to do. So even though we didn't see 100% improvement, it was the benefit of seeing a few things not improving that made the patient realize there was still work to do. So that's the magic of this that can really benefit the clinical process. So with the time I have, what I want to do now is tell you how you might be able to nourish your clinical teams. Now, if you're in an individual practice, you can think about what I'm about to share with you in terms of aggregating or grouping your data over time, especially if you're filing for accreditation or maybe you're trying to get a managed care contract. But one of the things that I get to do is I get to analyze the grouped data, and then I get to present it to Sierra Tucson. So I get to present it to staff. And I love doing it because, yes, I'm directing the findings really to the treatment teams who are doing the heart and soul of our work. But you know what? We have business folks in those meetings. We've got the janitorial staff. We've got intake departments in there. And what they get to see is the data showing how overall the patients that they're supporting in their unique way is making a difference. So I just wanted to share with you how this is nourishing from that more global perspective. And so what we have here is just a depression scale that we did last year during COVID, where we gathered data for the 3 quarters in 2020. And what we have here is the cutoff for depression here with regard to the CESD, which is the Centers for Epidemiological Sales Depression. That's the depression measure we use. And we can see that the addictions patients did a remarkable change over 2.5 weeks of treatment, going below the clinical cutoff. Our mood patients improved the same slope of the line. We saw a very similar slope with the pain patients, and our trauma patients actually improved. So overall, what we found was a 45% improvement. Is this a statistical analysis? No, but it's just general data to show improvement generally. I'll do the statistics later, but we're presenting it to my teams. It's more along the lines of looking how good we're doing. And we can say the same thing with the trauma symptoms as well. So we use the PCL5, which was developed by the Veterans Association, and we can see all groups across the board have overall improvement. And it's really a celebration of what we do here as a community to support the process. So I'm going to end there. I'm going to remind you that data are your friends, but I'm going to take some questions to see what I can do to answer any of those. So let me go ahead and pop this out. And I don't know how much time I have left, but my team will tell me. Do you recommend any particular measures to use with clients? Should there be a core set of measures that should be used? Also, what about the free measure that doesn't require a licensing fee? Thank you for that question. It's a really good one. Measurement-based care does not require a psychologist. So psychological testing is unique to the clinical psychology field. Measurement-based care is not psychological testing, and this is it's not a supplantation of it. It is an additional component to gauging treatment progress using psychometrically sound symptom rating scales. Does that make sense? So we don't really want to use the data that we're collecting as diagnostic, and any good clinical psychologist will tell you that they're really not diagnosing with their assessments as much as they are providing a preliminary diagnosis for you, the therapist, or you, the psychiatrist. So there are very good public domain free scales that are available for us to use, and they tap into all of the domains that matter to us in the work that we do. Depression, anxiety, trauma. There's a whole host of things you can do. I would always recommend looking at quality of life functioning, because think about this. It's not so much changing and helping to reduce symptom severity in your patients, but how are they getting on with life? And I think quality of life is often overlooked, and we really need to measure functioning as well in terms of symptom reduction. Which measures do you use in your evaluation? That was another one, great. So we use the CESD, which you saw, we use the PCL5, and we use a combination of PROMIS scales to measure anxiety, sleep deprivation, and pain interference. We look at a whole host of things in addition to quality of life. And I'll end there by saying our quality of life measure comes from the World Health Organization, the QOL brief, which is one of my favorites because it looks at the domains of functioning in terms of social functioning, environmental functioning, emotional functioning, and physical functioning. And I think we've run out of time here. And so I just want to thank you so much for your opportunity and your joining me today. And I hope I've convinced you to use more measurement-based care.